Welcome to the U.S. Healthcare System Lecture Series by Monika Wahi, based on Essentials of the U.S. Healthcare System by Shi and Singh. Welcome to Chapter 4, Healthcare Providers and Professionals. In this lecture, you will learn about all different types of healthcare providers and professionals, and you may even recognize yourself or your friends. Chapter 4, Healthcare Providers and Professionals. Learning Objectives. At the end of this lecture, students should be able to explain why healthcare professionals make up such a large proportion of the U.S. workforce. The student should be able to name 3 types of allied health professionals, also to describe the role and value of non-physician practitioners, to be able to list 2 differences between primary and specialty care, and finally to understand the role of dentists, pharmacists, and other doctoral level health professionals. The U.S. healthcare industry is the largest employer in the U.S. It's 13% of the U.S. labor force. So over the years, the services offered and the types of healthcare professionals available are closely linked. Obviously, as they have started to develop more of a certain type of medicine, they needed more specialists in that area. I remember in the 1990s, we did not have doctors who specialized in medical informatics, but now we have many of those. That's partly due to market justice. As soon as people wanted medical records, they needed physicians who could help implement them, and therefore the market put pressure on physicians to specialize in that. Likewise, the distribution of types of services and types of providers has evolved over time. Currently, today, there are imbalances. There are just too many specialists and not enough generalists. This is called a maldistribution of practitioners, an oversupply of the wrong type and an undersupply of a different type. This situation creates roles for NPPs, those non-physician practitioners, physician assistants, and nurse midwives, and those roles are increasing. Let's think about all the different kinds of health services professionals we now have after our healthcare system has been evolving for so long. Look at all these different circles, but one of the biggest circles really is allied health professionals. We don't hear so much about those, but we'll hear about them today in this lecture. Allied health professionals include therapists, lab and rad technicians, social workers, and health educators. Maybe your life has been touched by these people, and you probably didn't realize they were allied health professionals. In addition to the evolution of the different types of providers there has also been an evolution in healthcare settings. Certainly mental health centers have changed over the years, as you can imagine, as have laboratories as we have done more research and added more technology. Imagine the evolution of the different types of outpatient facilities. I could go on and on. The persons employed at health service sites has also changed over the last 10, 15, 20 years. Let's start by looking at 1994. In 1994, there was a certain amount of chiropractors, a certain number of dentists, more physicians' offices and clinics. But as you can see, as we went through to 2001 and 2009, really the only lines that changed on this are hospitals and other service sites. Hospitals was already the highest, and it really went up. The other service sites, well, what's that? Look at that diagonal line. That's basically where we have other types of outpatient facilities which evolved between 1994 and 2009. Those were added already to the physician offices, the dental offices, the chiropractic offices. All of those facilities stayed there, but then other kinds of outpatient service sites were put in place. And now look at that. As you can see, then, when you look at this slide, the greatest proportion at any given time of persons employed at health service sites have been employed at hospitals. Even though outpatient care has grown, as you can see by the brown portion getting bigger as we go through time. That's those other service sites. So that has gotten bigger. The question is, what has gotten smaller? Look, there are fewer chiropractic offices. Dental offices haven't been affected much, but there are slightly fewer physician offices and clinics. So as you can see, certain things go away and other things show up. Now let's talk about physicians. Let's look at the slide of the average physicians per 10,000 population in the United States. Let's start with 1950. So for every 10,000 people, there were almost 15 active physicians. So imagine a small town of 10,000 people. There might be 15 physicians. That changed as we went up through 1960, 1970, and 1980. When you think about it, that 15 went up to past 20 by the time it got to 1990. Today, in that same small town, you would have over 25 of physicians. So more of the population was becoming a physician, and more physicians were available to the population. Doesn't that seem like it should increase access to care? Let's look at the type of active physician. If you look at doctors of osteopathy, which maybe some of you have never even heard of or never even seen, you will see that they were not very prevalent in 1950, and they have gone up a little bit from 1980 to 2009. But still, many people don't know much about doctors of osteopathy, even though they're still going strong. We are more familiar with doctors of medicine, the MDs. You see, they were already more prevalent in 1950. But look at what has happened to them. In a way, it looks like DOs have doubled in size. And what has happened with doctors of medicine? Well, they started out in 1950 at about 200,000. But look at that. In 2009, they're over 700,000. That's like over tripling. So why did everybody suddenly become an MD? Well, let's look. MDs had a choice between becoming an MD and becoming a DO. This is because MDs and DOs have the same training, but DOs have a little bit of extra training. MDs train in allopathic medicine, which is the regular medicine we're used to. DOs train in osteopathic medicine, which includes training in allopathic medicine, as well as extended training in chiropractic, acupuncture, and other modalities. MDs are way less likely to be generalists. Only 1/3 of MDs are generalists. This is because allopathic medicine does not really emphasize a holistic approach. However, DOs are way more likely to be generalists. Greater than a half of them choose to be generalists rather than specialists. And this is likely because osteopathic medicine emphasizes more of a holistic approach. Now let us look at the differences between primary and specialty care. If you have ever accessed healthcare in the United States, you are probably familiar with primary care. Whether you have a headache or a rash, you cannot usually go immediately to the headache specialist or the rash specialist. First, you usually have to go to your primary care doctor. He or she is your first contact with the healthcare system and serves as a gatekeeper to the specialty care that you may need for your headache or your rash. Your primary care doctor is longitudinal, so whether it's your headache one day or your rash the next, you are always starting by seeing your primary care doctor, and so that person can keep track of you in the long term. That person gets to know you and gets to know you as a person as a whole. Not only do they know about your headache and your rash, but they know about when you adopted your child, when you got married, when you graduated, and other things that might have an impact on your life. Primary care doctors have generalist training. They're good in general settings, and they kind of understand all different kinds of diseases, but they don't specialize in any one of them. On the right side of the slide, you see attributes of specialty care. This is only tapped into when it's needed. If headaches are too bad or too confusing for the primary care doctor to address, he or she may call in specialty care. That's the gatekeeping function. And there, maybe the headache specialist can help. It requires a referral from the primary care doctor, and of course it's episodic. Often, even just a consultation with a specialist giving advice to the primary care doctor is all that's necessary. Then the primary care doctor can take it from there. Specialties are generally organized around a particular disease or organ, and they have specialized training for that particular disease or organ. On Aggregate, we have a physician oversupply. As I showed you in the earlier slide, the rate of physicians per population has really gone up. So you would think that we all could have access to care, but actually it's not that way. In Aggregate, we have too many physicians, but when you look specifically at it, we don't have enough OBGYNs, we don't have enough pediatricians or internal medicine doctors, and we don't have enough general or family practice doctors. We have too many specialists. Since specialists are just supposed to be used episodically and only when primary care can't handle something, and often just for a consultation, when you have all these specialists hanging around and not enough gatekeepers, it's hard to get through the gate. In addition to that kind of a maldistribution, there is also a geographic maldistribution, meaning that most of all of these physicians are in the urban areas and very few are in the rural areas. So whether you need a specialist or a generalist, you're kind of out of luck. So that's why when people talk about a physician shortage, you have to realize there's not an aggregate physician shortage in the United States right now. There's an aggregate physician oversupply. There's a specific shortage in primary care docs. We need those people so they can get us through the gate to the specialists only when they're needed. Let's look at ambulatory visits by generalists and specialists in the U.S. in 2005. Ambulatory basically means that these people are not inpatient in the hospital. They're just going to clinics and visiting these people. As you can see, 40%, or the purple portion, are visits to specialists. The rest are considered generalists, OBGYN, peds, etc. It seems that we should really have it be more, right? Because if specialists are episodic and consultational and they seem to just sort of support primary care, shouldn't almost all of these visits be not purple? Well, that's not the way it was in 2005, and I don't know how it is now, but I would not be surprised if the purple part has gotten bigger, simply because there are just more specialists. Let's talk about dentists. There are different dental specialties, and in 2008 you can see how they were distributed. Overall, 85% of the people who go into dentistry become dentists. But you also have orthodontists, oral surgeons, and all other types of dentists. It is interesting when you look at dental care and also dental insurance, especially when you look at public insurance. It is interesting to see what is covered by Medicare or Medicaid and what is offered. Dental care is very important. If you do not take care of your teeth, you can get cardiovascular disease, which is painful and expensive. So therefore, keep an eye out in the Affordable Care Act to see what kind of attention dentistry gets. If it gets no attention, expect chronic disease. Now we move on to pharmacists. Pharmacists worked in different places in 2008, but as you can see, most of them worked in retail. However, you will see a growing number of pharmacists working in hospitals, not just at the hospital pharmacy, but they may be consulting with physicians. That's because they are specialists in mixing drugs. They can help you not put the wrong drugs together. They can help you choose the exact right drugs. They're very good at that. And now that there are more drugs and more people in the hospital doing confusing things by having multiple drugs, we might need more pharmacists in hospitals. There are also other places where pharmacists work. There are other doctoral level health professionals who have not been discussed yet that we will talk about now. Here are some examples on the slide. On the leftmost side, you see optometrists. However, the high spiky one is psychologist. We have a lot of psychologists, and remember, these are doctoral level health professionals. Podiatrists are very useful, especially if you have a foot or back problem, and we have some of those. But we have a lot more chiropractors. Nursing has been an important profession for a very long time, and now it's only going to become more important. So let's talk about nurses. Nurses are the largest group of healthcare professionals. They have World War II beginnings, and so they're very well organized. In World War II, they were the major caregivers of the sick and injured patients, and they always have been. Nurses do more than what physicians do when it comes to quality of life for patients, because that's really what they do. They address physical, mental, and emotional needs. Nurses who are listening to my lectures here know a lot about the things that I'm already talking about. That health really isn't just the absence of disease. And nurses have been at the table for a while, and they keep becoming a bigger and bigger group of professionals. Because they keep becoming a bigger group, and as you know, healthcare is evolving and becoming more complicated, the levels of nurses have become more complicated and also continue to evolve. You have RNs, which require ADN diploma or a BSN. You have LPNs and LVNs, which require a state-level certification. And then there are APNs, which are NPPs, include CNSs, CRNAs, NPs, and CNMs. Look at all this alphabet soup. I was talking to an LPN the other day who said that before you could be an LPN and make a living, and now you can't. Now you need a BSN. So nurses are evolving as well. And their employment locations are evolving, so what they do evolves at those locations. Many practice locations exist for nurses. They can practice home health. They can work in the hospital. They can practice at clinics. And in many of the new outpatient settings that have evolved recently. Nurses can develop setting specialties, like they can be specialists in long-term care or in public health. And there have always been, and they often are, staffing issues. We go through periods where there are terrible nursing shortages. Nurses are very important. Now let's talk about non-physician practitioners, or NPPs. We're going to talk about the most common NPPs, and these were measured in a 2008 survey. You will notice that the biggest part of this is the yellow part. 67% of these NPPs are nurse practitioners. This is a special type of nurse. So these are non-physician practitioners who are very highly skilled. Nurse practitioners have a lot of experience and a lot of training and certification. And look where they work, exactly where we have a shortage of doctors, in primary care. Now let's look at the next biggest chunk, which are physician assistants. They make up 30% of the NPPs. Those physician assistants are more 50-50 split between primary and specialty care. So just like maybe a little more than 30% of the nurse practitioners are in the specialty care field, you have about 50% of the PAs in the specialty care field. And you can't blame them because there are so many doctors in those fields, they're going to have the jobs there. One thing you want to watch out for in the future is a bigger role for certified nurse midwives, the little blue chunk. Certified nurse midwives can really help you have a baby. They can do it cheaply, and they can really improve your quality of life while doing it. So you will see an expanded role for them. Let's talk about the role and the value of these NPPs. On one hand, they have less training than an MD or a DO, but more than RNs. Less training means you can get them on the job quicker. And you can also maybe change the supply of certain types of nurses quicker because they take less long to train. Not just nurses, but like we were talking about, but NPPs in general, the physician assistants as well. They are called physician extenders, so they work closely with physicians. Physicians are busy, we all know that. Anybody who has seen a physician recently in the United States realizes that that physician often just doesn't have time to talk with you. However, NPPs may have more time, and therefore they can talk with you and interface with the physicians for you. They do not cover the entire range of primary care, and they can't deal with complex cases, but then these are routed to the physician. However, most of what happens in primary care is not complex, it's routine. And so most of what happens in primary care can be addressed at some level by NPPs. There was an expansion of NPPs in the 1960s in primary care. Since then, we've been able to study it, and we find that clients are often more satisfied by NPPs than physicians. Well, why not? The physician doesn't spend much time with them, and the physician is really focused on them from a medical standpoint and not from a quality of life, holistic standpoint, the way NPPs have the luxury of doing. We have some current issues. First of all, there are state-by-state legal restrictions on what NPPs can do when it comes to prescribing or doing certain procedures. Also, insurances make up rules about reimbursement. They might not reimburse for certain procedures if they are done by NPPs and not by physicians. And often NPPs are shut out of decision and policy making. They aren't the AMA. Remember that big black circle of allied health professionals? Well, let's get to those people now. What is an allied health professional? Well, it's interesting that they are 60% of our U.S. healthcare workforce, but they seem to hide in the dark. A certificate or a degree is required in healthcare science, so these people are well educated. They deliver health or related services, and you've probably interacted with them without realizing. They can identify, evaluate, and prevent disease and disorders, even though they're not NPPs. Sometimes they are involved with dietary and nutrition, and some are rehab experts. Further, there are those managing our health system. These are allied health professionals. Here's some more information about them. On the left side of the slide, you see technicians and assistants. These type of people need less than 2 years of training. PTs and OT assistants, who you may have interacted with if you've gone for physical therapy or occupational therapy, those are the ones who help the PTs and the OTs. You have laboratories, radiologies, and respiratory techs. All these techs need to be trained and deployed to help this health system run. These are often the people that you need to talk to when you're deploying an electronic medical system or anything else that will change a workflow, and that's some sort of technology. Also, look on the right side of the slide for the technologists and the therapists. These have more training than the technicians and the assistants on the left side of the slide, and in fact some of those technicians and assistants go on to become technologists and therapists with advanced training. These are the PTs or the DPTs and the OTs, D being Doctor of Physical Therapy. Dietitians and nutritionists are also in this category, as well as dispensing opticians, speech and language pathologists, and social workers. Now that you see what type of allied health professionals there are, you might realize that you have interacted with them, or at least wanted to, if you don't have access to healthcare. Finally, we get to my favorite part, because I am public health. I am on the slide, because I am a public health professional. Here are our core disciplines. Well, first of all, you've got all these different kinds of people together. I happen to be in the second block. I'm a researcher. But there are physicians too, and there are attorneys involved with all of our work. In fact, I've learned quite a bit about law from them. There are environmentalists who really care about how the environment interacts with health, and there are also social scientists who are worried about how culture and things like injury and violence affect our health. I'm specifically an epidemiologist. We study the distribution and determinants of disease. And we use biostatistics to analyze all of our data. I specialize in epidemiology, which is the study design, but I have friends who are biostatisticians who specialize more in the statistics. There are health service administrators too. Those people specialize in managing healthcare systems and big projects. There are health education and behavioral science people in public health, and these people go around trying to educate the public and trying to do mental health prevention. Finally, you have environmental health that tries to weigh in with what the environmentalists are finding and tries to do what they can do to improve health. Let's look at health services administrators. See this pyramid? Just like those assistants in the allied health professionals who can go on to be technicians, you have at the bottom of this triangle places where assistants to mid-level managers who can supervise small teams who have a bachelor's degree can maybe go on and move up the triangle to the top. In the middle we see people who lead outpatient or nursing services, department managers, and people who lead logistics and operations. Sometimes these people also have nursing degrees or MD degrees, but then they have to get one of those degrees in the box on the right. A Master's of Health Administration, for example. You'll notice the one that is red is the one I have, which is a Master's in Public Health. Finally, at the top, you have leadership, strategic direction, and governing boards. These are like hospital boards, which we'll learn about in Chapter 8. People have to be trained to run these things, and sometimes they don't need much training in how to be a clinician, but more training in things like accounting, in management, and leadership, and how to implement electronic medical records, things like that. Practical leadership training. And so that's what health services administrators do. In conclusion, as healthcare evolves, we are challenged with the maldistribution of physicians. NPPs are needed to help, but there are obstacles there as well. And there is a strong role for nurses and many career opportunities for nurses at different levels. As you can see, in the past, healthcare has been different, and we have had different distribution. But as market pressures and social pressures have exacted themselves on us, we now end up with this weird aggregate oversupply of physicians, but then this maldistribution. Other healthcare professionals have various levels of training, diagnosis and treatment authority, and roles, and these people are going to have to step in to help us with this maldistribution. These people include dentists, public health professionals, health service administrators, and people who handle pharmaceuticals. We've come to the end of the lecture on healthcare providers and professionals. So now you should be able to explain why healthcare professionals make up such a large proportion of the U.S. workforce. You should be able to name 3 types of allied health professionals, as well as describe the role and value of non-physician practitioners. You should be able to list 2 differences between primary and specialty care. And finally, you should be able to understand the role of dentists, pharmacists, and other doctoral level health professionals. I hope you enjoyed this lecture about healthcare providers and professionals. They are some of my best friends and probably some of yours. Stay tuned for the next lecture over chapters 5 and 11, Technology and Vulnerable Populations.